Good evening to all. Because this topic is selected by Amila. He put 1,000 cataracts, so better to will change into high volume surgery. So what I would like to talk here, certain slides you can keep as an individual peripheral surgeons to use for your cataract control management strategy. Otherwise, you have to learn from various community medicine and other department. The second part, what each and every district or provincial surgeons, you all have to plan individually, not from the local common thing. Then individually, you have to plan and control the cataract. So this is why I told. So in northern province, we had done more than thousands in 3 occasions. One 2021, actually you all know that's complete lockdown before vaccination. The national Vesak celebrated at Jaffna. They planned to celebrate it at Jaffna district, the Sri Lankan cultural ministry, but unfortunately they couldn't do that. But the cataract part we have done. The second one, this Friendship Week, Radnavura and Jaffna, we did 1,000 surgery, 1,000 plus. And the third one also we did at DGH Vaunia, Indo-Sri Lanka, that collaboration from the government, and we did again 1,200 cataract. So why these high volume surgeries we had to do? I put these 2 words. This is the future of Sri Lanka. So don't think in future the health sector never going to give full complete IOL and consumables drug forever. That's already they have accepted. So we need a public-private partnership, and because human resource management crisis in all aspects, so we need some sort of multiple stakeholder involvement depend on your district and the province. In Sri Lanka, it's not uniform from all 25 districts. So the high volume surgery, why we have to do? That's also very simple. You have to reduce the waiting list. Now the waiting list is more. You all know that part. And the second part, cost involvement. You all have to manage that. And the third part is very important to reduce the carbon CO2 emission. This carbon global warming and carbon forming is a hot topic. Now that's a common topic. Now all are talking. Next. So this is actually, I'm not going to deal. This is only the cataract blindness. So 19 million blind, 81 million people visually impaired. We have to consider these all WHO protocols over 50 years, and low and middle income country. I don't know Sri Lanka at present, it's which level, maybe low, I don't know. But cataract surgery is very effective and relatively simple. So you all know, whatever, we have to be very proud. So we are the only country in the Asia Pacific region, in the African continent, so South America. We are the only one doing for the community aspect. So whatever the aspects, we are doing phaco. Phaco is the mode. Few cases only we do SICS or what. So here only big problem, you all know cataract amount and all you can calculate from your surveys and all. But how to do it and how to control this cataract blindness, that's a big challenge. So only 2 factors you can consider in your districts, right? These 40 plus population, that means we have only 1 survey is available. Blindness is 1.7%. That means less than 360 vision. It's the blindness. So you can district, population, province, you can simply calculate how many patients in my district, in my province, we have blindness. So 1.7, but you have to adjust to the cataract just for the 50 years. That's simply you can do the calculation. And one thing, and 67% roughly, 65, 70% due to cataract blindness. So our severe cataract blindness coverage is 85%. These are 2 factors enough for you to do. And depend on your district, province, you can make your definition. WHO is telling now at present for us also less than 680. But you all can make it even 660 or 3/65. First you have to give the priority now to reduce the blindness. So after last year APAO, Northern Province, we have, according to their suggestions, we have gone for less than 612, because that's equal to high income country, because we are doing massive numbers and we are reducing this one. So basically the three things here, you will have to be very fast, you should know. Primary, we studied in community medicine those days, primary prevention, secondary prevention and tertiary prevention. Primary prevention, we don't have anything. That's why cataract is the big market for us, because there is no drugs or preventive methods to reduce the opacification of the lens. But the tertiary prevention only, we are talking these less than 3/60 cataract blindness due to cataract, you had to treat and revert the vision. In between, less than 3/60, or that means the secondary, other cataracts, visually impaired cataracts, we are allowed to deal with that. So that little bit, that's enough. These actually don't study too much. This is actually, you can keep the slide, output, cataract out. These three terminologies important for the strategic management. Actually, unfortunately, for eye surgeons, we had to do medicine, surgery, as well as preventive and this community work also in Sri Lanka. So you all should know a little bit. So cataract output is deal with the numbers. That means CSR, how many cataracts you are doing for 1,000 population, or 1 million for 1 year. That's simple. And cataract coverage you can calculate. And cataract outcome is very important. That's now they are mentioned in your STG goals or whatever. Effective cataract surgery. So we are doing all cataract surgery. Now we have done a study, we are going to publish. We are doing phaco. Our cataract without glass, without any intervention, 95%. More than 95%, no need the glass. That means high quality. That's very standard. I think, hope Sri Lanka, everywhere it seems to be same. And cataract outlay, that part we never think, we failed. Previous government, so we spent the government money for each cataract, 95,000 to 100,000 per cataract. Now at present cataract project, we are spending 16,500. So why we failed and our economy also collapsed? Because this is one of the reasons, health income wastage of the money. So you can't do like that. But this is also higher in our Asia Pacific region. But other countries, they are spending, because of the SICS, we are the only one doing phaco, because of the machines and all we are using, we are now spending 15,000. But other countries, they are just giving 5,000 in India, Bangladesh, Pakistan, other countries, Nepal, Bhutan and all, just $20, $50, even the Afghanistan. So cataract outlay is finance management cost. That's important because it's a big health budget. Basically, the cataract output, I have already mentioned. Two things you should know. Cataract surgical rate. Simply, you all know how to calculate. 1 million population, 1 year, how many cataracts. These cataracts, we have to be very careful. The total cataract, if you want to tell, for an example, Colombo district or Western province, it should be all the cataracts. That means private hospital, public hospital, your charity hospital, everything. But extremely, you all know, difficult to get even the private government hospital data to collect. So you have to be somehow to have something for your future management. And then the cataract output, there are two words you already knows, that incidence and the prevalence. Prevalence, very simple diagram. No need to study too much or don't confuse. If anything, waiting list plus community cataract is prevalence. And what you have to do, we have to calculate and put each your district and the province, new cases coming inside. That means the cataract severe blindness, every year 20% will come in your cataract blindness course. That's normally the WHO already calculated. Now if you have 10,000 cataracts, mean 20% every year you have to expect these cataracts are significant, we have to do. So that cataract should be done minimum for the cataract surgical rate in your district and the province. Very simple. The coverage just for your these things. This you are seeing every time, because some people doesn't like even this Vision 2020 or Inside 2030 and all. This is the WHO, the global targets. So for our country, yeah, they are just thinking 30% of the effective cataract surgery. What is that effective cataract surgery? High quality surgery, not the number. That's why I have already mentioned. It's cataract outcome, not the output. So we have to see the output, cataract output, then we can consider for the cataract outcome. Right, so the second part, now this is also one other hot topic. So this is the only health system. Now there are endocrinology, physician, everyone is there. But the high health, The high health is related to directly or indirectly related to all 17 parameters of sustainable development goals. So SDG goals is very, very important for the country economy. That means that's actually the parliamentary budget. So the high health is positively giving input to the parliamentary budget for the positive budget. Right. What I will want, I want the second part to share that the northern province experience to that. So simply why I put northern province, Jaffna only we have that permanent surgeon. Now only the Dr. Giridharan came to Vavuniya is going to be permanent. So far we don't have any facility. You know the Mullatthivu district and Manna, there is no surgical facility, no eye surgeon. On and off that few SRs will come. After that they will vanish. Most of the people, they won't come back again. That's a real scenario in future also. So that's why we can't leave because our population and all that, just put northern province. We always do with that because we have the lot of, because more than 10 years I am working. So you know roughly the population now you can see 1.2, but not 1.2, now is 1 million. Now all the people are now is migration syndrome, like COVID syndrome. All the people are day by day moving. So Vavuniya population within 3 months, 30,000 people gone down. Right? Okay. I don't know where they all went to Canada, but fortunate, I am very happy those moving very fast. So 1 million population, you keep it like that. So in my province, there are western province, there are so many province eye surgeons are there. My province, this is the important. You have to have the good networkship. Then only you have to work out, write a good proposal and get the attract grants. 80% is the rural community, you all know, after the 3 decades of the war. Very low median income people also in our province. So that's our, anyway, speciality. Pockets of severe poverty, that also here. Then the other one is up country, right? Okay, Sabragama province and the center. And minimum cataract surgical centers, only 3 centers available at present. Main center is Jaffna, 2 district centers are, and low human resources. Jaffna is the northern province, a dangerous place. If anyone comes, suddenly they may disappear. That means all are going to abroad, right? Whoever the specialty, not the eye surgeon, I am not blaming. So we are the transient centers. The transit airport like that. So northern province, if anyone comes, then we have to be very danger. Suddenly they may miss and vanish. Right, so these are the 5 factors. So this is very important. I think all eye surgeons, so even the senior register, you will have to go through how I did the calculation, right? For my province, 1 million population. So blindness rate 1.7, 40 years. Then you can adjust into 50 years. Then my cataract rate less than 60 is the 10,000. Minimum it should be there in my province. So every year incident, 2,000 because of the 20%. These are all calculations. It's very simple, right? Then what will happen? I had to cover, is my duty. The Siemens sir told those days, before Vision 2020 and all. So 2,000 surgeries we had to do at northern province, right? So at present, northern province, we are doing last year more than 10,000. That's why our levels are little higher. And now this year, we are going to reach more than that. Even 15,000 we are going to do it. Including private and the government hospital, excluding the other province patients. Right? Okay? This is 5 district project. That we have data, no issue. So you can see that formula. That formula is very simple. Surgical rate per million. Everything is there. No need to study anywhere. Right? Less than 3 by 60, 1,300 cataract. If you make it 612 as your cutoff line in your district or province, so you have to do 1 million population, minimum 6,000 cataracts. So both cover because we are covered beyond that. Right? So that's why our waiting list and all we are going to reduce or 0 maybe in next month. We are going to declare. So Sri Lankan CSR rate, you will have to get it because as a workshop I have mentioned, these are all published data. 2,000 to 1,300. You can understand now simply CSR. And 2009, we have reached because of our successful Vision 2020 program. What the expectation be beyond that, 3,300. And 2015, we reach even that, even better, 5,300. But after that, what happened? COVID, economic crisis, collapse. I didn't mention anything, significant drop, but I knew because of the calculation from the epidemiology and other department, now we are equal or less than 3,000 overall in Sri Lanka. That's not good, because already they have mentioned geriatric population increasing, waiting list increased years and years, and significant blind cataracts also everywhere is available, slums in the western province or rural area. So this is, we have to consider. Why we have to consider? Because I will tell on the last slide, because of the STG. So after that, what is our problem now? We don't have any government health provision is out. That means health ministry budget, even the Panadol, sometimes we don't have in our teaching hospital Jaffna. So the cataract, they're never going to forget. They're never going to give anything at all. So the only way forward in Sri Lanka is a public-private partnership. That's extremely important in any field, right? That's why there are a lot of IMF, etc. So various reasons. So this is the only way we can make. The DG came, that's why I put this photo. And other thing, we have an issue. Eye surgeons will leave, optometrists will leave. Now the health assistant also moving. 25% missing in the Vavuniya hospital, right? 25 last month. So all are leaving from the country. I don't know where they are going. So then multi-stake involvement also important, multi-stakeholder. You know eye surgeon, you know what are the things you need to perform eye surgeries and all, then you have to train. And we developed that protocol called the comprehensive patient-centered care. Now you see, those days when we were students, I think all are here, pre-op admission, do the cataract surgery, the post of the following day we will send. Minimum 3 days. Nowadays, not like that. So early morning we had to admit, I'm admitting, within 2 hours they had to leave the place, otherwise they may create the problem in the ward, right? So after that what will happen? Even that we are giving 1 month drugs. Most of the people never turned up, even the follow-up also. If you ask, I can see why I had to come. Only the people, the education or government servant only coming for the glasses, for the near vision correction. So you will have to make sure that depend on your surgeon. That means the beginners, you have to be very careful, but when you experience and you all experience, I think you can do that part. That's very important. Patient-centered care pathways, that's correct. Theatre efficiency. Don't think ideally for all the theatres that everywhere same. Now for me it's okay. There are theatre Vavuniya, only 3 days you can work. Sometime 1 day per day to work. But don't forget, because that is a reason to not to do the cataract. You can do something to follow all these things. Efficient theatre management for the high volume surgeries or whatever, even normal volume. Strategic. You have to have the cost saving also, because last time put all the Centurion machine, the gazette sleeves and everything in the hospital is a white elephant. Now the white elephant we are maintaining. We bought, that's why. So the rationalization of the post-operative, you have to be very careful. First visit, third visit. There are a lot of patient money waste, our time as well as. So if you are confident, 1 month you can give and send, unless any complication you can keep or you can continue. And you have to identify the sustainability and the carbon footprint. This is very important nowadays, otherwise you can't get the grant. So you have to demonstrate that I am getting. For an example, in British, 1 cataract, 2.5 kilogram waste for the CO2 emission. But in Asian, in our model in my department, I am wasting only 200 grams, 150 to 200 grams per cataract surgeon. All these things will be published in journal, right? So India. So we are the good model in Sri Lanka, right? So carbon footprint is very important. And the program should be sustainability. That's very, very important. At least we are not going to be health sustained. At least the country economy, you have to be sustained through the cataract surgery program. That's why important. I just put one slide. What is the benefits of public-private partnership? Not for the eye. You can go for any healthcare or whatever. This is the only way forward. If you want to raise the country little bit higher. Right. So how we have made that depend on our pluses and minuses. You have to do what is called SWOT analysis or something. Weaknesses, strength and all. This is very simple. You can do it in your own way. One MO or one nurse with you. You can do that. So in my province, I got these things, the Alanda Alaka Foundation, the Assistar now, entire country, they are providing. And Ministry of Health, you got to have the good network. That's very important. Don't think I am line ministry, I am in the province. Provincial ministry is very important. Eye health ministry is important. Even for me, I don't have the minor staff. So I have always trained the Palali Army Hospital. Palali Army Hospital, we have enough staff. So all the nurses and the doctors will come and work. I think last time the KDU also came, and they realized that the Palali Army Hospital people are now 50 people I have trained. Even with that, so any strike also, the army won't strike, right? Okay. So I can do that. So this is the way. Now if you take any other district, don't go for the army. Anuradhapuram, you can take it. Polannarva, okay. Certain other districts, you can get the youth clubs. So the Namal, Rajapaksa youth clubs. So many clubs are there. So any clubs you can take. You had to train, whatever. That's okay, whatever. See the web. I use the vision care because vision care people, at least they know something in the eye. So that's why even the Anandi private hospital, the pharma companies doing all the CSR work. Alagan, they are doing the drug packing, health education material, digital health transformation, everything they are doing in Sinhala and Tamil. And Alcon guys will come and provide the technical support free. If I do the camp or 3 machines if I operate, the guy will come for free of charge. And they provide even the IA, irrigation, IA. So this multi-involvement depend on your lack of facilities in your department. You have to get them, get the good relationship. Night you can give a boost or whatever, right? Whatever way, you have to attract them and do, and you have to finish your task, mission and vision. That's a way, that's called multi-stakeholder involvement. It's not universal. If you go to Kandy, it's a different. Then the Kandy, the Amaduru, then you know, they are very strong. And you can get the Pansala people to get the youth clubs and all to do. Because he is already agreed. Even Anuradhapuram he told. Rohan Velisaya and all, they told. Tandrimale and all. They told they will support. Even they try to give funds also. But I can't go and do there. Right, so the multiple stakeholders, you have to identify the donors. You have to mingle and you have to do. That's why the public-private partnership and multi-stakeholder. Right? So now I have finished this. This is the slide. Why we had to do cataract? That's very important. No, then we can leave it. No, why we had to do? If you do the cataract surgery, these things are going to, I publish these things. If you do the cataract, free cataract surgery, the poverty you can reduce, zero hunger, good health and well-being, decent work and economy. You see, 50 patients from the one bus I did, the female, Mullatthivu affected area, Kokkulai. They are female-headed family. There is the males are died due to the war, grandmother or mother. So I did the cataract. That lady's previous income is Samutti Fund or some relief from the ministry, but now they are earning 100,000, 1 lakh per month. Ladies. Why? Every day they go to catch these prawns, 1 kilo 1,000, 5 kilos they can catch in 2 hours, 5,000 per day. We are going to publish these data all. What is the cataract? That's why the recent economy. So these are rural community, our community, even the tea estate, rubber estate and all. If you do that, you can get it. Then you can get these sustainable cities and community. You know the road traffic accidents in north and there are frequent fall in the Odavidic water, all bilateral cataract those days. Right? So you have to, you can tell, even here also same. Bilateral cataract, they all. Even snake bites, 5 cases within 1 week. Why? They can't see at all. So this is 5 years before, right? But I am telling, these are all evidence. So this is okay, interesting, but okay. And that 12th is a climate action. Partnerships is the 17th goal that we are implementing. The 16th one only just for, this is all peace and regulation. You know, I am doing for Anuradhapuram and other district patients to enhance the relationship, faith and all. So that's the only reason. And you see, these are all statistics. What we are doing now, already Manna, Mullatthivu patients, next week we are going to have no waiting list. Jaffna, this last month, no waiting list. So we can't wait on that. So we had to do the screening. On the satellite cleaning you had to do. Hospital waiting list, prevalence, but outside. Outside, even Vanni district, now the 56th Army Division. Army Division, I have trained Army, that health assistant and there are 50 soldiers. They should know how to check the vision. House to house, they go with the MOH. And they do the stage 3 screening at Vanni area. Vanni area is the largest area in all 3 districts. 56th Division Army is doing quite effectively. Within 3 months, we are going to finish. So these are all screening we had to do for the Inside 2030. And this is the cataract. So at present, 60% we are doing at Jaffna Hospital. We have 4 surgeons can do. District surgery, because I am doing the intermediate card. Even the one SHO, trained SHO, without complication, he can do. and all the trainees depend on that. And we are teaching also district general 20%, Jaffna, and the private is only 10%, right? Don't think too much. Jaffna private is only 10%, right? So you know what is the benefits of free cataract surgery, how we are doing, what is the important, and how to do the units and all, right? Okay, very simple. So take home message, this is the only way forward. This is not a political speech. Public-private partnership and multi-stakeholder, you to achieve the good health, because they are going to privatize education and health very soon. Prevention and control cataract blindness, you have to do district and provincial level under national policy. District and province, each district is different. So this you will have to be understand. Though the eye surgeon should, district eye surgeon, provincial eye surgeons take the lead. And sustainable program you have to draw, and you have to increase the CSR. One way you have to do the mass camp initially, or with high volume surgery, and you have to innovate your own effective screening model and cataract surgical model. That's important, depend on the district. Thank you.